Welcome to episode 2 of Endoscopy Essentials of colonic EMR with Michael Bourke. Michael, welcome again.
Thank you.
We have talked about the preparations and what to do if we have flat lesions, terminology, how to measure them. Now we go into the image part. So what kind of lesion is that? What are the different classifications? How reliable are they? Observer dependent, and images we are very keen on.
Yes. So this is, this is a large non-pedunculated colonic polyp.
It's all over the place, huh?
Yeah, it's an adenoma. It's probably half the circumference. So it's
which you see on the left side.
Yeah,
a little bit.
Which we see on the left side, maybe 4 centimeter lesion, and 4 to 5 centimeter. And you can see if we look in overview mode, it's homogeneous. We don't see anything that sticks out at us that says, oh, look, there's a focal depression or a dominant nodule or an ulcer or something else. It all sort of looks the same. And I like to use the analogy, a bowl of rice bubbles, Rice Krispies it will be. Mm-hmm. Yeah. And then when you flick on the MBI, it would be like Cocoa Pops, you know. So you can see that it's a homogeneous lesion. And it's flat and it's multinodular. So this is a granular lesion. It's like a bowl of rice bubbles. It's flat. So then we say it's a Paris 2A lesion.
So important is there are nodules all over the place. They are of similar appearance. None really stands out by size. And there's this granular, non-granular. So this is granular.
This is granular. We have some non-granular examples.
Okay. So this is granular. Everybody would agree. Okay, let's look at some other.
Well, we can just look. So the steps are, so you look in overview and you make an estimation. So we've covered those things: location in the colon, straight scope, clean the lesion thoroughly. I mean, if it had adherent mucus, we can go down that. We haven't covered serrated lesions yet, but we'll come to them, I presume. So this is an adenoma, and we see. We look at it in overview, and then we look with focal interrogation. So we become closer, we use near focus, and we examine the pit and microvascular pattern. So here you can see on this image here that this is like a cerebrum. There are crypts that are branching, and this is a Kudo pit pattern type 4. But again, it's regular. And so if you see that it's regular, so if you were like a psychedelic individual, you could, have this as wallpaper in your bathroom or something like that. There's no derangement to the pattern, and the same with the vascular pattern. You
have to do this with the entire lesion, so square centimeter by square centimeter.
With such a lesion, no, but with focal interrogation, we say focal interrogation because we want to focus on any area that's either depressed or dominant nodule and observe the pit pattern in that area.
So you take your overview and then you take some random close-ups?
No, you say, right, well, that's the biggest nodule, right? So we go and look at that. And then if we're in doubt about the morphology of that nodule, we compare it with the surrounding mucosa. So the real-time comparison you can also do this when you're looking at an adenoma, and you can say, well, is that adenoma or not? Well, that's normal mucosa. This is so then it reminds you, this is small regular pits, and these are branching longer pits.
Right. So it's not that you're looking for the 500 micrometer spot, which might be a little bit irregular, because then you get crazy.
Yeah, you don't need to go nuts, because when we say that, and we've shown that in a flat lesion, you can reliably detect, if we're going to talk about it now, submucosal invasion, early submucosal invasion, because
it stands out.
It stands out because
even from some distance, I'm
going to show some examples.
Yeah.
You can see it because you have. I like to use this term, lesion homogeneity. So the lesion is homogeneous, and both in overview and also in focal interrogation. We don't sit. I mean, this vascular pattern. This would be even better in your bathroom. Look at it. It's so regular and it's repetitive. So there's no dominant dilated vessels, interrupted vessels, amorphous white patches or anything like that. So this benign lesion.
Because the background of my question, a little bit provocatively, is that I've seen quite a few live demos where somebody said, this could be a little bit irregular in the intention to do ESD. And of course, histology next day shows low-grade adenoma. So that's not the challenge, right? If it's homogeneous, overview-wise, you have some focal views, then you can be not 100%, but very, very sure that this is a benign lesion.
And also, we know from using big data where we've enrolled 3,000 to 5,000 of these cases, like not just 10 or 20, but thousands of these cases above 20 millimeter. When we classify them by Paris and surface morphology, and location, which is very important, we know that the risk of invasive cancer. So this lesion, flat, granular 2A in the right colon, the chance that there's cancer in that lesion is less than 1%. Yeah. And whereas if we see the same lesion in the left colon, the risk is increased, but it's still low if there's no dominant nodule. And I want to get back to that idea of if you have a flat lesion versus a lesion with a nodule or big bulky component, I like to use the analogy of the pizza versus the calzone. So the pizza, you know exactly what's in the pizza because you can see, there shouldn't be pineapple, but there's pepperoni, there's a whole range of ingredients, but you can see all of them. So when this should just be like a margarita pizza. It's just all homogeneous. And then when you've got the calzone, if there's a big nodule, you don't know what's inside. So that becomes more difficult. And then we have to rely on location and other factors to stratify for the risk of invasive disease.
So this is a benign lesion. Let's go to more pictures.
Okay, yeah, so this lesion, so these are all cases that were referred to us. And so what we see here is that so they're all referred as ostensibly benign lesions for endoscopic resection. And when we look carefully here in white light, you can see this is not homogeneous and the edges are poorly defined.
A little bit bloody, which is also a
yeah.
concern,
When you irrigate, if it starts to bleed, it's a concern. So all the lesions I'm presenting, they're all clean, right? But they don't come this way. They have a lot of adherent mucus and everything. So everything's been cleaned up, and that's an important step, as we emphasised. And then you can see here that when we look carefully, you see here this is the regular type 3 pit pattern at the edge, and the type 1 pits here, and this is the demarcation line between the edge of the lesion and the normal mucosa. And then we come up here, and suddenly we have loss of homogeneity. I like to say this is not the same lesion. There are at least two different bits. And here we see we can't follow the vascular pattern, nor can we follow the pit pattern into this white area.
Which is sufficiently large that everybody would recognize it. So it's mostly composed of ugly tissue, maybe, or ugly-looking tissue.
It is actually deeply invasive cancer.
That's the other side of the spectrum.
Yeah, but this was referred by, all these cases are referred by nationally accredited endoscopists. And of course, in a referral centre, we have the benefit of seeing like 10 to 20 of these lesions every week, at least 10 larger than 20 millimetre. And we see lots and lots of them. We have people to talk to. We're not just there by ourselves. We do have time pressure, but not so bad. And so everything is optimised for us to make the right decisions. But very simply, this is not a homogeneous lesion. There's loss of pit and microvascular pattern centrally. And in fact, the loss is so bad, you can't even follow any pattern. There's a lot of amorphous white areas. This will be deeply invasive cancer.
Okay. But there's a huge area, grey area in the middle, right?
Grey area.
So this is a non-granular type lesion?
Yes.
Yes. Which has a malignancy risk of?
Depends where it is in the colon and on its morphology. But if it's in the right colon and it's flat, the risk of cancer is only about 4%. And but if it's in the left
this
colon,
one?
No, this is a cancer, but
yeah,
this is 100% cancer.
Everybody.
But I'm just saying for all comers, that case that's deeply invasive cancer. I don't even need to see the histology,
Then which means surgery?
It's 100% surgery. Can't be resected endoscopically.
Okay. So we have both ends of the spectrum.
Correct.
Now we have the cases in between.
This case should not go to endoscopic management. This is deeply invasive cancer, deep SMIC, submucosal invasive cancer. This part don't take a biopsy first. Make a spot mark first on either side, 2 to 3 centimeters distal from the lesion. Then take tattooing. Yeah.
Not into the lesion.
Not into the lesion. Just 2 to 3 centimeters distal, and then take your biopsies at that point. You don't want to make your tattoo after you take your biopsies because the channel could be contaminated with malignant cells. And then, very importantly, extensively photo document the position of the tattoo in relation to the lesion, and make lots of images. Make sure you've got a straight scope. Be careful about where you are, and then patient goes to.
I think we should reinforce the tattooing message, not into the lesion, because if the primary assessment was wrong and it could be endoscopically resectable, then you make the life much more difficult. If you tattoo underneath the lesion.
Yeah,
that's a common mistake, by the way.
Very common, very common. I would say of all that, we don't see so many cases referred to as with tattoos, because I've been a bit anti-tattoo unless the patient's going for surgery. But there's a proportion that have even if the tattoo is done in the right spot, there can be sublesional diffusion of tattoo, and the sterile carbon particle suspension is not sterile. It's sterile but not biologically inert, and it creates fibrosis. So you can have.
So if you want to make the endoscopist's life very difficult, you tattoo underneath.
Yeah, not very, but more difficult.
Oh, yeah. Okay. Well, I would say very. Anyway, so we have the two extremes. Let's go on to the gray zone, the huge gray zone.
So in overview, these are other lesions. So you see on the left and on the right, particularly on the right up here, this is a non-granular lesion. You see the surface is smooth, and they can have this stellate appearance. You often see them in the transverse colon. This is the transverse, obviously, and this is also more like a non-granular lesion as well. And this, of course, is a granular lesion, mixed multinodular, lots of small flat nodules here, and then two big dominant nodules. And even in overview from here, you can see that the surface is not homogeneous. So here we see an abnormal area. In here, this is abnormal. And here. So these are, there's already a clue, an overview after we've cleaned that this may not be a benign lesion. Yeah, 3 different examples.
With a risk of between 10 and 30%?
Well, we have to look a bit more carefully to decide, but it's going to be 100% in these 3 examples. Yeah. So then when we look more carefully, I think the center one is the best example. Now, this is benign tissue up here. But here we have, there's a depression and there's contact bleeding, and there's loss of at this distance, we can see loss of pit and microvascular pattern. So this is.
But again, a non-granular lesion, if it's rather homogeneously non-granular, is not per se malignant. There have to be additional features like centrally here.
Flat.
Yeah.
If it's a nodular lesion, so just to make this important distinction, in flat lesions, the surface expression of cancer will usually be visible, and we've shown in a study of 2,500 cases that the accuracy of the sensitivity of endoscopic detection of invasive cancer is reliant on morphology. If the lesion's flat, the sensitivity is 95%, specificity 95%, and risk that you'll miss cancer in a flat lesion is 6 in 1,000 cases. If it's nodular, then the surface expression of cancer may not be on the surface. And so the expression of cancer may not be on the surface. So you can easily miss cancer. So nodular lesions are in a different group. You can't reliably say there's no cancer in that lesion. And then it becomes reliant on location in the colon to decide what the risk is.
But if I was an ESD proponent, that's all ESD. If
you're an ESD proponent, everything's ESD. But we know, I don't know if you want to look.
No, later. We'll have
hearty congratulations to the French, but.
We'll have a separate session on that. But if you look at all those, there's a high suspicion of malignancy.
Yeah.
Right. One is a big polyp nodule. So it's the size, and it could be underneath and above some.
Well, in these cases, we can see.
No, the upper middle.
This one?
Yeah.
Oh, yeah. But so there are 3 cases in this direction. Sorry. So that is the same as that. This is a nearer focus.
Ah, okay.
Yeah.
Okay.
Yeah, and this is focused in on that irregular area. So I should have made that clear.
But if you take the upper picture, you see something reddish, and this is the area where you will focus, and then you detect that there's
Correct,
something
'cause
wrong because it's
usually-
irregular, bloody, etc.
Yeah, usually if you see a big nodular lesion like this, then the nodularity is sort of low, is homogeneous in a way. It's all going to be flowering outwards. But here we see this is, it's missing its nodule, this area. And then if we look more closely, there's a sharp cutoff here to this, dusky area with, you can't follow the pit or, this. So this is cancer here, deeply invasive cancer.
Okay. So
and then
here
if we
have,
look even more carefully, you can see. So with the MBI, we can follow in these three separate examples. So regular pit and microvascular pattern here, loss of pit and microvascular pattern in this depressed area, same again, and same again. So these are all deep cancers, referred for endoscopic resection by nationally accredited endoscopists. Yeah.
And the conclusion here is again surgery?
Surgery, 100% in every case. Mm.
Good. So
you must not attempt endoscopic resection.
So Michael, very nice examples. I would like to dig in the gray zone. There must be benign lesions which look a little bit suspicious but are still benign. Can you show us more examples?
This might be considered such an example. So here's a granular lesion and there's a little depression in the middle. So then we always worry, could that be significant? Because the lesion's essentially flat, we can look and interrogate with what we believe is good accuracy, good sensitivity, 91 to 95%. And then when we look carefully with NBI, you can see we don't have a near focus image here, unfortunately, but in this image, so in overview, we see some depression, and then in near focus, with MBI, we see the pit and vascular pattern, or pit pattern, we can see it's still homogeneous. There's nothing, you can't see anything of great concern there.
So the message is it's a 2A plus C?
No,
Right?
it's not. No, because that's a pseudo depression. So C really means a true depression, which is sharply demarcated with.
And that's a good point. So it's a relative depression. So it's flat in the middle and elevated at the rim.
Yeah, but not a true depression. And that, it's a great example. It is a grey zone. So we wouldn't call this 2A plus C. We'd just call it 2A because plus when you add the C, it means that there should be a high risk of cancer, which I think in this case.
So it's always measured according to the plane of the surrounding mucosa. And
Correct.
the C should be deeper than the surrounding mucosa as far as this is really accessible, right?
Correct, yeah.
But at least it's something to look at. And if the central depression or the central flat area is normal, like and has a granular pattern?
Yeah, when it's got a discernible, the thing is it's got a regular discernible pit and microvascular pattern, not disrupted, then you can be relatively confident that there's no invasive disease. At the time, when we have gazillions of these images, but at the time, when we made this slide, we were doing a study looking at the relative, the incremental benefit of dye staining. And so we randomized, we did it sequentially in 400 of these lesions above 2 centimetre. And so you can see here the dye staining, it's helpful because you can see there's no loss of the pattern. It doesn't seem to be anything to be concerned about.
Do you have to deflate a little bit?
Deflate and inflate, I think, both, and take your time. This is with methylene blue. We showed no incremental benefit in 400 patients. It's published in GIE, I think. So then we just do EMR.
Okay, if you see that and the middle area, whatever it is, flat depressed, it looks normal, looks microgranular or granular, then you go on with EMR. Is the lifting also a criterion?
Yeah, the lifting's important, but again, it's not binary. It's like there's there's non-lifting and there's non-lifting, and it's influenced by I mean, we think submucosal fibrosis, previous attempt, lesion biology, for sure. Non-granular lesions have a lot more submucosal fibrosis, and they tend to lift. When you lift a granular lesion, you can get nice vertical elevation. But when you lift a non-granular lesion, it's more diffuse. It's like lifting something in the stomach. You know, when you lift in the stomach, you never get that nice elevation. Everything goes up together. So that makes endoscopic resection more difficult by piecemeal EMR technique. So, yeah, I mean, non-lifting, it was historically a tool that came into being before we were so good at imaging. So I don't think the utility of it is not as good now, and I don't rely so much on it because the other reasons for non-lifting, you can have extramural injection. There's lots of reasons. So it has to be factored into the decision-making process, but it doesn't stand alone as...
Okay, good. So I love that image. Okay, Michael, a few more examples from your magic box. Difficult lesions, seemingly.
Yeah. Well,
what's this one?
Well, this is a flat non-granular lesion in the proximal colon.
Is it totally non-granular or?
It is, yeah. I believe it is, because in overview, you can see they often have this stellate appearance, and even with white light, you can see the edges relatively well in the top two images, and it's flat. It's all non-granular. So there's no real nodular component.
And this middle thing there at the margin?
It's a little scar. No,
did somebody work?
It's possibly a site of previous resection, but you can't be sure. Depends on the honesty of the referrer. And also when you start to resect the lesion, that can inform the process. So the next step is to evaluate. It's a flat lesion, right? So we should be confident that we can make an accurate evaluation of the lesion. So then we go with NBI in overview. This is just a little unusual here, but I don't think it's anything to worry about. But I understand why
it's a little bloody. So
yeah, I think it's okay. Because the pit pattern here, see, this is all regular, small pits. That's normal mucosa, and you can see clearly the edge of the lesion here. There's some glare there, and so this is all fine. And then when we look with the near focus mode, you can see the pit and microvascular pattern very clearly, and this little crevice here is a biopsy site. Yeah. So that can create confusion, but the referrer would have taken a biopsy from there. And so sometimes you get that appearance. I mean, there's nothing here. Everything leading into that little absence is regular. So that's a biopsy site.
And it goes into the EMR box.
What do you mean? Sorry?
That goes into the EMR box. You do EMR in this lesion?
Yes. Oh, yes.
It's benign. So there's something which is a little bit...
like, so in Asia, 100%, this lesion has never been done by EMR. And in the West now, you'll find people arguing that we should be doing this by ESD because it's a non-granular lesion. It should have cancer in it, but it doesn't. Because I'm looking at it, I can tell it doesn't have cancer.
But it basically shows you that something which looks a little bit ugly, you know, maybe an ulcer or something in between, it's non-granular, so alarm lamps. But then you go closer and you have a closer look, and it looks more benign.
It looks more benign.
Okay.
And in fact, and we can tell by the pit and microvascular pattern that this will be a tubular adenoma with low-grade dysplasia probably, you know. Okay. And in fact, I know we haven't touched on resection, but it's just to make the point that this was part of a randomized trial of cold snare resection. So we do cold snare resection, and then we do thermal ablation of the margin.
Okay, well, we'll come to that.
But I know, but just to make the point how confident I am that it doesn't even need to be removed by hot EMR. It can just be done by cold.
So, Michael, next example: difficult lesions looking ugly.
Yeah, this is a challenging lesion to evaluate. If you look up here at the top right, so there's a little bit of mucus here, so that should have been cleaned a bit better. But overall, we can see that this is a granular lesion with a homogeneous pattern, nothing to be worried about. And then when we move away from that area, over here, we can see that there are a number of nodules. This lesion's in the proximal colon. But the nodules create concern for the risk of invasive disease, which is not zero. It's a few percent probably.
Again, a bit bloody.
Yeah, well, yeah, but that could be from the scope, or I don't think it's from water jet. Yeah, yeah. So, in fact, we removed this lesion by EMR. It was just a TVA with focal high grade. I want to point out, we haven't touched on resection yet, but I want to point out something very interesting that I just noticed here. Now, if you look, when you excise a lesion, at the margin you always have a crisp diathermy image, and you have a crisp diathermy white line where the submucosa is interfacing with the epithelium. But here we see this crisp white line. That is the line of excision of the muscularis mucosa. So it's like the target, but above the target. And here, this lacy capillary, this is incomplete mucosal layer excision here. Yeah, we have a paper on this coming out in GIE. Maybe you're a reviewer, I don't know. But so this is another reason for recurrence. If you believe that you've removed this...
It's not removed.
It's not removed. Yeah, there's residual adenoma there. And you can see that appearance with cold snare excision now, because the plane of excision...
You're taking off the grass, but the...
the plane of excision is in the deep lamina propria, but not in the superficial submucosa.
Okay, so there was
it's a segue.
A preview to the resection status, but there are so many nodules. Why are you not concerned?
Because this lesion's in the right colon, we know from our own data based on thousands of cases that the risk of invasive disease with this 2A plus 1S granular lesion, it's very low, less than a few percent. So we would not do ESD here. If this lesion was in the rectum, 100% ESD, because the risk of invasive cancer could be 10, 15, 20%. Okay. But it's very much influenced by location.
But from the very first case in this episode, you showed us you would have to do a close look onto the nodule.
Yeah, we have. Well, that's assumed.
Or nodules.
We have to evaluate all of this very carefully. Yeah. We don't see any disruption. These aren't big nodules. Maybe the biggest is 10 to 15. So I think, there's no surface expression of anything concerning. So I think you can take this dominant nodule in one piece, this one in one piece, and remove the rest by EMR.
Still low likelihood?
Okay. Low likelihood, and you can see here the end result, the beautiful clean resection.
Okay.
If we do it by ESD, this is a 3-hour case. If we do it by EMR, 3-hour case for a Japanese endoscopist, I'm sure. And if we do it by EMR, for me, it's like a 30-minute case, 30 to 40 minutes. Yeah.
Okay. So, Michael, we could go on forever, but one final example for this episode?
Yeah, so this, obviously, these are two lesions assessed in parallel on the one slide here. Obviously, when we do a procedure, often when people come to our department, they say, "What's going on? I see 50 pictures." We take lots of pictures, so I just synthesized this down to, what's necessary to present in the slide. But this is a comparison between granular and non-granular lesions, I think both in the transverse. And you can see this is mostly a 2A granular lesion.
Pretty bulky on the left
side. Yeah,
side.
It is bulky, yeah. So, but again, the surface is smooth, and so I'm not concerned, but there's a small risk. The risk is not zero of cancer. And this non-granular lesion, again, very smooth, almost like they're in the same part of the colon, same colon. When we look carefully, there's no disruption to pit or microvascular patterns. So in our practice, we remove this lesion by EMR. If this lesion was in, the sigmoid or rectum, same with this lesion. If this was in the rectum, then we'd definitely do ESD because of the risk of covert cancer, because there is a nodular component. But in both cases, we've done EMR, and this is going to be a tubulovenous adenoma, maybe some focal high grade. This will be a tubular adenoma.
So again, the message is bulky lesion per se, granular lesion per se is not a reason to make alarm.
Yeah.
But you have to make the close look.
Yeah.
And the first examples you were showing, there had something ugly in the middle, irregular, etc. These are sort of regular.
Yeah.
Bulky but regular, granular but regular.
Yeah, granular with the bulky components, so 2A plus 1S, but maybe the colon's not fully inflated, top left-hand corner. And this was, again, part of this study looking at the utility of methylene blue chromoendoscopy, no additional benefit. Nothing to be concerned about, so we do EMR. This area is removed en bloc, this nodule, take that in a single piece, large piece, and the rest of it can come out by EMR. Very efficient, safe. And then this other lesion, non-granular lesion, it's presented here as a contrast to the other lesion. A nice smooth surface. In overview, we don't see any disruption. It appears relatively homogeneous. And again, with MBI, again, homogeneous. This is just and so again, we do EMR. There's a little bit of submucosal fibrosis there.
Okay, so we have to come to an end for this episode, for this session. And the main message is it's the close-up stupid, isn't it? So you have your overview, you decide it's a granular type, looks homogeneous, that's done. But if you have potentially suspicious lesions, like bulky lesion, like granular part of it, then you have to go into details. And the assessment takes a bit longer then.
Yeah, I wouldn't say it's the close-up stupid. I'd say it's the looking stupid. Like, just look carefully and look carefully in overview. And is it homogeneous? What type of lesion, granular, non-granular? Well, of course, we're just talking about large adenomas. And then if you see any area, depression or nodule, carefully examine in focal interrogation. Look at the pit and microvascular pattern. Is there disruption to that or not? And if that's all clear, there's no disruption, it's homogeneous, then you're almost certainly dealing with a benign lesion, particularly if it's in the right colon. Left colon and rectum, there are other considerations we'll come to later in the series.
Okay, perfect.